Good afternoon, ladies and gentlemen. Now we are starting the session of gynecology, systemic treatment and surgery. We'll start with Dr. Ghada Refat. She will talk to us today about the practice-changing studies in advanced and metastatic cervical carcinoma. Please, the floor is yours, Dr. Ghada.
Thank you, Mr. Chairperson. Thank you for the attendees. So sorry for the harsh voice. I'm glad to be a part of this hopefully successful session. Our talk today about the practice-changing studies in advanced and metastatic cervical cancer. So for those diagnosed with locally advanced disease, the standard of care, of course, is the cisplatin concurrent with radiotherapy and brachytherapy. And this is the mainstay treatment till now. For the patients with metastatic disease, which is inoperable or the local treatment couldn't be achieved. So the treatment typically consisting of combination chemotherapy, which is giving some local control and some systemic control, but actually no long-term survival. And the intent mainly is palliative, and long-term survival is late. The preferred combination therapy consists of cisplatin and paclitaxel, or carboplatin and paclitaxel. So an alternative chemotherapy regimens stated in the study in 2009, including cisplatin, navalpine or cisplatin topotecan, cisplatin Gemzar, and they were not superior, but it is comparable to cis-paclitaxel, with different, of course, toxicity profiles. And bevacizumab role before 2014 was actually a single agent in heavily pretreated recurrent cervical carcinomas. And the second line consists of single agents like paclitaxel, topotecan, carboplatin, and others. But however, the objective response rate does not exceed 25% by all means, with significant toxicity with the repeated lines. So 2014 was the start of the new role of bevacizumab in advanced cervical cancer. In the GOG 2040 study, the addition of bevacizumab to different chemotherapy regimens, namely the Taxol carboplatin and the topotecan paclitaxel in the recurrent, persistent, or metastatic cervical cancer has significantly increased the overall progression-free and objective response rates compared to the chemotherapy alone. And according to the analysis of the quality of life in the same study and in other studies following, there was no affection of the health-related quality of life. So this was the randomization of the study. It was the addition, it was 4 arms, 2 chemotherapy regimens with and without bevacizumab. No prior anti-vascular endothelial growth factor was allowed, and no prior chemotherapy to the advanced disease. So there is significant progression-free survival with the addition of bevacizumab, 8.2 versus 5.9 months, and median overall survival increased from 13.3 to 17 months. And also in this plot, we can find that the ages from 48 to 56, performance 1, the recurrent or persistent disease, and the squamous histology and the presence of the pelvic disease. This was an advantage, or this translates to a better survival in addition to bevacizumab to the chemotherapy regimen. But of course, with a different toxicity profile and increased the occurrence of fistulas, especially the gastrointestinal, the hypertension, and the thromboembolism, and also neutropenia. So the breakthrough was in 2021 with pembrolizumab is used in many cancers and was presented to many cancer types and presented in the cervical cancer for persistent, recurrent, or metastatic patients. And this was the keynote 826. It was a phase 3 trial with patients with advanced and metastatic cervical cancer, and pembro addition to the first-line platinum-based regimen. This is with or without bevacizumab, provides progression-free and overall survival to all the population, not only who expresses the PD-L1, but for all the PD-L1 less than 1 or more than 1 or more than 10. This was the randomization of the study, the eligibility criteria, and the certification factors. And the bevacizumab was also added to this combination according to the investigator wish. In the 617 patients in the intent to treat population, progression-free survival that was achieved with the addition of bevacizumab to the chemotherapy, it was 5.9 versus 8.2. Now it is a step forward from 8.2 to 10.4. And the median overall survival to the first time of the history of the advanced cervical cancer reached 2 years in the intent to treat population versus 16 months in the comparative arm. And of course, there is a different adverse events criteria or toxicity profile in terms of anemia and neutropenia, especially grade 3 and 2-5. And this is for all comers, or the PD-L1 less than 1 or more than 1 or more than 10. And it is achieved in all comer population. Advance in the progression-free survival or prolongation of the progression-free survival and progression of the overall survival. And this is the curve of overall survival. In PD-L1, the combined score is more than or equals 10. In 2029, this was like the interim analysis of the keynote, and this is the final analysis. So it was an update to the keynote 826 that was published and presented during the ASCO 2022. And it reached the same results, that the addition of pembro to chemo plus or minus Avastin significantly reduced the risk of death by 40%, and PD-L1 combined score more than or equals 1, and by 37 score in all comer population, including the negative PD-L1, and 42 in the combined score of more than or equals 10 population, with a manageable safety profile. An important point to say that the pembro and chemo benefit was regardless of the beva use. And this data is consistent with the earlier results of the same study, providing the support of the pembro plus chemo plus or minus beva as the new standard of care for the first-line treatment of persistent, recurrent, or metastatic cervical cancer. So what about the second line? Before 2019, pembro was not used as a second line, but it was introduced. And now, if it's not used in the first line, it can be used as a single agent for patients with tumor PD-L1 expression or high MSI. But what about the newcomer in the second line for metastatic disease? This was introduced 2021. It is the tisotumab vedotin. It is a tissue factor-directed antibody and microtubule inhibitor drug conjugate, specifically for the use in metastatic cervical cancer that has progressed on chemotherapy. And this is a short note about the tisotumab vedotin. It is an antibody drug conjugate that targets a tissue factor that is also called thromboplastin or factor 3. And it is highly prevalent and prevalent also in cervical cancer. And it binds to its target and it releases agents that inhibit the cell proliferation, resulting in apoptotic cell death directly into the tumor cells. The study is innovative V204 study that uses the tisotumab vedotin as a second-line setting beyond through in this study showing a mean objective response of 24%, which allows for the fast approval of this molecule by the FDA in the second-line setting. This is the key eligibility criteria of the study. It is for second line, as we said, so if the patients progress during or after doublet chemotherapy with bevacizumab and received less than or equals 2 lines or 2 regimens of systemic therapy. And performance again is ECOG performance status 0 to 1. The primary endpoint was the overall response rate, the time to progression, overall survival, safety. And these were the percentage of the complete response and partial response patients. The patients achieved response, the objective response rate. And this is the assessment of progression-free survival and overall survival for the patients received the agent. And the most common side effects, as we see, is the alopecia, the epistaxis, nausea, conjunctivitis, fatigue, and dry eye. And lastly, and it's worth to mention about the 2 studies that are mentioned in the last ESMO in Madrid in this October 2023 about the locally advanced cervical cancer. There are 2 studies with different population, although they are both in the locally advanced session. But one, which is the GCIG Interlace trial, used the induction chemotherapy before concurrent chemoradiation, and they found that it improved the outcomes in the locally advanced cervical cancer in the terms of progression-free and overall survival. It's worth to mention that 77% had stage 2, and more than half of them were lymph node negative, and this is a very important point. They are somehow an early patients in the advanced stage patients. So we have to be cautious about this. The progression, the overall survival changed to 72%, and the progression-free survival rate of 80% instead of 64. Yes, of course, grade 3 adverse events were added, receiving the induction chemotherapy. There's also a very important point to mention that the induction chemotherapy, which actually a study that currently taking place in our department in Ain Shams, but there are many challenging points that we should consider. This study worked to work strictly in the regimen, 6 cycles Taxol carboplatin, then maximum of 7 days, then concurrent chemoradiation and brachytherapy. And this should be considered. This is the progression-free survival curve of Interlace study and how it could differ from the adding of induction chemotherapy to the concurrent alone. Another one in the ESMO this year is the Keynote A18, is the addition of checkpoint inhibitor, which improves the outcomes in the high-risk locally advanced. So in the previous study, we are not high risk. This patient, most of them are stage 3 and most of them are lymph node positive, and there is a significant improvement in progression-free survival. Overall survival data actually was not mature enough. So the combination of pembro and concurrent was shown to have a manageable safety profile and very promising significant improvement in progression-free survival, and this awaits further investigation. Thank you very much.
Thank you, Dr. Ghada, so much for this elegant presentation. Question is floor for a couple of minutes for any question. Okay, thank you so much, Dr. Ghada. Now we will have our dear Professor Dr. Mohammed Abou Al-Futuh, and his talk is about application of the new guidelines for advanced endometrial cancer.
بسم الله الرحمن الرحيم. أولا بشكر حضراتكم على الدعوة الكريمة، وأنا دايما يعني بسعد بوجودي في مؤتمر عين شمس. النهارده التوك بتاعي على الابلكيشن of the last guidelines for advanced endometrial cancer. I will start by some basic knowledge about endometrial cancer, then we'll move to the metastatic or advanced setting, and at the end, like Dr. Ghada did, I will go through two abstracts just come out in the last ESMO. So in the last 2 decades, there is a shift from treatment for one for all to selected treatment approaches for endometrial cancer. We have a lot of randomized trials about the role of lymphadenectomy, laparoscopic surgery, radiotherapy, chemotherapy, immune therapy, and target therapy. And we have changed from treatment, as I said, from all to risk-adapted or risk-based adjuvant therapy, as we have as you all know, the ESMO and other guidelines who stratified patients to risk groups. The current directions concentrate on improved survival for high-risk patients, de-escalate treatment for favorable prognostic endometrial cancer, decrease toxicity and enhance quality of life, and we have molecular basis for treatment of endometrial cancer with new targets for therapy, and we have individualized risk assessment using the molecular characterization. Factors affecting treatment decision, the pathological subtypes, we have some aggressive types and non-aggressive types. The molecular subtypes, as I go through quickly in the next few slides, tumor grade, LVSI, focal or none versus extensive or substantial, and the FIGO and TNM staging, and the risk group like ESMO, ISGO, ESTRO consensus guidelines. For the histological subtypes, we have the endometrioid carcinoma of low grade, this is grade 1 and 2, and we have the aggressive histological subtypes like endometrial carcinoma grade 3, carcinosarcoma, serous carcinoma, clear cell carcinoma, and undifferentiated carcinomas. This is the new FIGO just come up in July 2023, and now we have the designation 1C returned back to the stage 1, but with different characterization, and now they included the pathological subtypes and aggressive versus non-aggressive in their staging. Also, they have included some molecular like polymerase epsilon and B53 abnormality in their in the staging, and we have again for stage 3 and stage 4 some changes. For stage 4 we have it now divided into 4A, 4B, and 4C, and they separated 4B into 2 groups: peritoneal, is 4B now, and organs and like liver and lung into 4C. And this is the algorithm how to do molecular subtyping. You start by testing for polymerase epsilon, then we test for MMR, then we look for B53 in order to divide into the 4 molecular groups. Endometrial carcinoma with polymerase epsilon ultra mutated, and with endometrial carcinoma with mismatch repair deficiency and no specific molecular profile and B53 mutant. And as you probably know from this is from the Portic-3, this molecular subtypes had different prognosis, with the best prognosis for polymerase epsilon, even if they are presenting with advanced disease, and the worst prognosis is B53 abnormality. And this is the risk groups. The ISGO, ISTRO, ISMO have this new risk groups, and now they included the molecular classification in order to classify patients into low, intermediate, high, and high risk groups. And this is quickly we have for the low risk patient no adjuvant treatment. For the intermediate risk patient, we'll have vaginal volt brachytherapy. For high intermediate risk patient, we have external beam radiotherapy, and for high risk patient, we'll have external beam with concurrent chemoradiotherapy or sequential chemoradiotherapy and radiotherapy or chemotherapy alone, and this is chemotherapy alone is level 1B, and while adjuvant external beam and concurrent is level 1A. And now we come to the main topic of this presentation is the treatment of recurrent or metastatic endometrial carcinoma. The treatment of patient with recurrent or metastatic endometrial carcinoma always requires multidisciplinary approach in specialized center. It should be guided by the patient condition, extent of the disease, prior therapy, and molecular profile. Some important prognostic factors like site and extension of recurrence. Is it isolated vaginal recurrence, pelvic or peritoneal carcinomatosis, tumor size 2 centimeters versus more than 2 centimeters, prior radiotherapy, relapse-free interval, and histology. We start with the first treatment dated since 1950s with the progestin therapy. The first publication by Kelly and Baker in 1961 showed the response rate was 29% among 21 patients with endometrial cancer. Factors reported to predict response to progestin is low-grade endometrioid histology, and to less extent the status of estrogen receptors and the progesterone receptors. Unlike breast cancer, estrogen and progesterone receptors are not predictive of response in endometrial cancer, and we have some responses in patients even with ER and BR negative tumors. The standard agent for hormonal treatment is progestin, either medroxyprogesterone acetate 200 milligram and magistrol acetate 160 milligram. And for first-line therapy, we have overall response rate around 23%, with a median progression-free survival of 2.9 months and overall survival of 9.2 months. Other hormonal agents like tamoxifen, aromatase inhibitors, and fulvestrant have shown lower response rate than progestin and are therefore regarded as second-line hormonal therapy. And from the ESMO 2020, we have this phase 2 study. They added palbociclib to letrozole, and this improved the progression-free survival to 8.3 months compared to 3 months, and disease control rate at 24 weeks, 64% versus 38%. Alpit with increased the toxicity. We have anemia in 8% compared to 3%. And as usual with CDK4/6 inhibitors, we have neutropenia 4-2 versus 0%. Then we move to chemotherapy. The standard treatment before this study was a protocol called TAB, and this was a comparator in this study, the GOG 0209, and included patients with stage 3 and 4 recurrent endometrial cancer with no prior cytotoxic chemotherapy. They give them TAB versus paclitaxel carboplatin. The endpoint was they were compared to survival and assess differences in toxicity profile like neurotoxicity and infection, and patient-reported health quality of life. And this is the survival curves for the both treatment arm. They overlap each other with no difference in overall survival or progression-free survival. But the TC arm was associated with significantly more frequent and severe neutropenia, hepatic events, and myalgia than the TAB arm, while the TAB was associated with auditory and severe auditory, constitutional, and fatigue, and cardiovascular, and ventricular function, and gastrointestinal, nausea, vomiting, diarrhea, anorexia, stomatitis, and elevated creatinine and thrombocytopenia. And the study treatment was discontinued for toxicity in 18% for TAB arm, 12% for the TC arm, and the overall toxicity and health-related quality of life profile favored TC Taxol plus carboplatin versus TAB, which appeared to be an acceptable and less toxic alternative to TAB, and now this is a standard treatment as chemotherapy for advanced endometrial cancer. Then second line, we have many agents like topotecan, dactinomycin, pegylated doxorubicin, oxaliplatin, pemetrexed, and other drugs. They have minimal anti-tumor activity in this pre-treated population with persistent or recurrent endometrial cancer. And this study have shown, some of this study, they have re-challenged with platinum, particularly for patients with more than 6 months of platinum-free interval, and they concluded that we can re-challenge with platinum in those patients with longer relapse-free survival. Then we move to immune therapy. Immune therapy with a checkpoint inhibitor, both PD-1 and PD-L1 inhibitor, is nowadays the most promising therapy for endometrial cancer, given that 30% of primary endometrial cancer are microsatellite unstable or have the mismatch repair deficient tumor, indicating immune dysregulation. Immune checkpoint blockade therapy has been explored both as monotherapy and in combination with cytotoxic chemotherapy. Now 2 drugs are approved by the EMA and FDA, the Pembro and the Sterlimab. And we start with the Sterlimab, and this is a study called the Garnet study in patient with recurrent or advanced endometrial cancer, including deficient mismatch repair genes by immune histochemistry, and patients should have received no more than 2 lines of therapy before treatment. And a study included 104 patients, but only 71 patients were for interim analysis. And by the end of this study, 29 still having the Sterlimab. And this is the efficacy results. We have complete response in 13% of the cases, 30% partial response, and 15% stable disease. And for side effects, mainly diarrhea in 15% of the cases, fatigue 14%, and nausea, with colitis in 2% of the cases, and 2% of the patient discontinued treatment due to side effects. Then we move to pembrolizumab, a non-randomized study, checkpoints inhibitor including Pembro had compelling anti-tumor activity based on overall response rate and duration of response in patients with MSI high or deficient mismatch repair gene in advanced endometrial cancer. However, only 16 to 31% of the endometrial cancer have MSI high or deficient mismatch repair. Pembro monotherapy showing less activity in patients with macrosatellite stable or proficient mismatch repair. And we study with this keynote study, they studied different cancers, non-colorectal, carrying mismatch macrosatellite instability high or this deficient mismatch repair gene. In this study, endometrial cancer, there were 49 patients, and they have overall response rate of 57% with a median progression-free survival at 25 months, and median overall survival was not reached in this study, including other tumors like gastric and cholangiocarcinoma. And we have the keynote 146 in advanced or previously treated endometrial cancer. We have in the mismatch stable, we have 2% complete response and 34% partial response compared to the deficient arm, 9% complete response and 54 partial response, but taking in consideration the low number of patients with MSI high in this study. Then we move to the famous keynote 775. This is including patients with recurrent or metastatic endometrial cancer of any histological subtype except carcinosarcoma and sarcoma with disease progression after one previous platinum-based chemotherapy and no history of exposure to VEGF or PD-1 targeting regimen. Patient must have received 2 platinum-based chemotherapy if one was given as neoadjuvant or adjuvant therapy. The endpoint was progression-free survival and overall survival. Secondary endpoint was overall response rate, safety, and health-related quality of life. The including patient with proficient mismatch repair, and the 2 arms with lenvatinib 20 milligram once daily and Pembro 200 milligram every 3 weeks, compared to either doxorubicin 60 milligram every 3 weeks or paclitaxel 80 milligram day 1, 8, and 21. And this is the progression-free survival for the patient with proficient mismatch repair, and for the old patient showed superiority of the lenvatinib plus Pembro, and also this true for overall survivor as well, both in the proficient arm and the all-comer arm. And by July 2021, the FDA approved Pembro with lenvatinib for patients with advanced endometrial cancer, neither MSI high or nor deficient mismatch repair, who have disease progression following systemic therapy in any setting. And in January 2022, the EMA approved the same regimen regardless of mismatch repair status. And this is for patient with local regional recurrence. If the patient receive vaginal volt brachytherapy only, they can receive external beam. For patient who didn't receive radiotherapy, they can receive external beam plus vaginal volt brachytherapy. For patient who received prior radiotherapy, surgery only if complete debulking with acceptable morbidity is anticipated. And for all arm, they must receive systemic therapy after local regional treatment. For patient with metastatic or recurrent disease, this is the ESMO guidelines 2022. They divided the patient into patient with low-grade endometrioid histology. They can receive hormonal therapy with progestin, aromatase inhibitor, tamoxifen, or fulvestrant, or chemotherapy, carboplatin, paclitaxel. For the other patient with MSI high or deficient mismatch repair gene, they can receive a re-challenge with platinum-based chemotherapy, or receive doxorubicin, paclitaxel as second line, or immune checkpoint inhibitor with dostarlimab or pembrolizumab. For mismatch stable or proficient mismatch repair, re-challenge with platinum-based chemo or doxo and paclitaxel and pembrolizumab is the as combination with immune therapy and target therapy for this group with MSI stable. And this is the NCCN guidelines. It has the same treatment like carboplatin paclitaxel as category 1 for carcinosarcoma and dostarlimab category 1 plus carboplatin paclitaxel, and we have the lenvatinib pembro for the mismatch repair profession. And we come to the last two abstracts. This is in the last ESMO, for the endometrial cancer or carcinosarcoma patient newly diagnosed with a recurrent disease with no prior systemic therapy. They were randomized in 2-to-1 fashion into carboplatin paclitaxel versus carboplatin paclitaxel and atezo with maintenance atezo. The primary endpoint was progression-free survival in the deficient mismatch repair population, and progression-free survival and overall survival in all comers as secondary endpoint. And the addition of atezo showed significant improvement on progression-free survival with a hazard ratio of 0.36, with a median progression-free survival not reached versus 6.9. The superiority was confirmed also for all comers with a hazard ratio of 0.74 and the progression-free survival of 10 versus 8.9 months. And the conclusion of this study was the addition of atezo to standard carbopaclitaxel chemotherapy demonstrated significantly improvement in progression-free survival in advanced endometrial cancer carcinoma with substantial benefit mainly in deficient mismatch repair carcinoma. And the second study, this is durvalumab plus carboplatin paclitaxel followed by maintenance durva plus or minus olaparib, including 718 patients randomized in 1-to-1 with carboplatin paclitaxel and carboplatin durva and maintenance durva plus placebo or carboplatin paclitaxel durva, maintenance durva and olaparib. The primary endpoint was progression-free survival and second endpoint was overall survival. And this is the results of the study with a median progression-free survival improved with a hazard ratio of 0.71 in the intention to treat population. And for the patient with durva and olaparib, the hazard ratio was 0.55. For patient with deficient mismatch repair gene, the carboplatin paclitaxel durva, the median was not reached, and the hazard ratio was 0.42. And for olaparib, it was the median was 31.8 months with a hazard ratio of 0.41. This study showing statistical significant and clinically meaningful progression-free survival improvement with the addition of durva to carboplatin paclitaxel, followed by maintenance durva plus or minus olaparib versus carboplatin paclitaxel alone. Maintenance olaparib further improved the progression-free survival in patients with proficient mismatch repair disease. And by this I end my talk, and I think these studies could change the guidelines in the next year by including both drugs in the guidelines. And thank you for your attention.
Thank you, Professor Muhammad, for this elegant presentation, and the floor is open for a couple of questions.
Thank you very much, Professor Muhammad. I have a comment and I have a question. Actually, recently, over the last few years, we have experienced higher incidence of local recurrence because most of the patients have been operated upon by gynecologists and the surgery is not complete. They used to either not to dissect the lymph nodes or to leave the cervical stump, which is not actually a good thing to do in such cases. And my question to you is, what's the role of radiation therapy in your mind?
For the local recurrence patient haven't received any radiotherapy, we can go for external beam plus or minus brachy. For patient even received the brachy, you can go for external beam only. But for patient who received the 4 radiotherapy before, they only have surgery.
Yes, but surgery could be anterior pelvic exentration, for example.
If possible.
If possible, I understand. But I think, from my own experience, we have tried with some few patients with recurrent disease. Either they were missed brachytherapy in the initial treatment plan. After a year of the primary treatment, we could repeat with high-tech like VMAT or IMRT plus brachytherapy, and we got some achievement.
For these cases, sometimes we have a bulky stump. We use the ring and interstitial needles in the brachytherapy for recurrence, not just the cylinder.
I missed the part. We start usually with few cycles of chemotherapy. They used to respond nicely to taxane and carboplatin. Then we apply the radiation therapy on the residual disease.
I think this is a valid option. You can do the bulking with chemotherapy and go for radiotherapy. For radiotherapy, we have many cases. We do the interstitial because of the bulk of not the cylinder like any post-operative case. Because sometimes you have the stump 2 or 3 centimeters, you will not reach with the cylinder. So we have ring and interstitial needles in order to increase the dose and
Okay, thank you, Professor Muhammad. And now I'll present my dear colleague and friend, Professor Ahmad Obaya, Professor of Clinical Oncology at Zagazig University. He will present a lecture about how to choose the PARP inhibitors in ovarian cancer treatment.
Thank you, Dr. Ahmad, for your introduction. Thank you, the organizing committee, for your invitation. I think my topic today is how to choose PARP inhibitors in ovarian cancer. Let's start with the problem of ovarian cancer as a disease. It's very aggressive tumor despite aggressive treatment received in the first line setting. We have 2018, according to GloboCan, 300,000 patients diagnosed with advanced ovarian cancer. About 60% of those population usually diagnosed in the advanced setting. And out of the 60%, 70% of those population will relapse in the first 3 years. In these relapsed patients, 30 to 50% 5-year survival. So we have very aggressive tumor and we need to optimize our treatment. If you look for the disease process of ovarian cancer, usually ovarian cancer has multiple relapses, multiple responses. And if you look for the first relapse after adjuvant systemic treatment, it is the longest time for remission of the disease. And if the patient relapsed after that, the remission time or progression-free survival will be shorter and shorter with each relapse. So the chance of the patient usually in the first time of treatment, because if the patient is relapsed after that, it becomes incurable. So we need to optimize not all lines of treatment, we need to optimize our treatment in the first line setting. And this is the trial to optimize the systemic chemotherapy, traditional trials that confirmed that carboplatin paclitaxel is similar to cyclophosphamide and doxan, and the carboplatin paclitaxel is equal to cisplatin paclitaxel. So after that, paclitaxel carboplatin becomes the standard of care, and after a while we adding some biological agent like bevacizumab in ICON 7 and the GOOG trial. We found that some improvement in progression-free survival with the addition of bevacizumab concurrent with chemo and then after maintenance with beva, and improving overall survival in some category of patients. So till that time, we have no further treatment in the first line setting except chemotherapy plus bevacizumab. After identification of certain group of drugs, which called PARP inhibitor, we found that these PARP inhibitors, this is the mechanism of action of PARP inhibitor, these PARP inhibitor inhibit the PARP enzyme that responsible for single strand break of DNA, not inhibition only of the enzyme, but trap the enzyme inside this single strand break, and with replication, this trapping prevents the replication of this segment of DNA, leading to double strand break in the DNA. If this double strand break in the DNA, this double strand break in the DNA present inside normal cell, this normal cell have a mechanism of repair of this double strand called homogeneous recombination repair, a lot of genes responsible for this process in the normal cells, so the breaks repaired and the cell survive. But in the malignant cells, if the malignant cells is deficient in homologous recombination genes by mutation or epigenetic effect on these genes, leading to accumulation of mutations and leading to what's called genomic instability, that leading to cell death. So PARP inhibitor is efficient more in malignant cells who have homologous recombination gene deficiency or process deficiency. Traditionally, genomic instability was identified as in patients with BRCA mutation. But after that, PARP inhibitor was effective in some population with BRCA wild population, and so we found that a lot of genes that are responsible for homologous recombination, not only BRCA mutation, and this group of genes called homologous recombination deficiency, was present in 50% of patients with ovarian cancer. So we have 50% of patients with ovarian cancer are susceptible to benefit from PARP inhibitor. This is a PARP inhibitor. First player was olaparib, and olaparib was approved in the first line setting based on the SOLO-1 trial as a monotherapy maintenance for patients with only BRCA mutant, not HRD. This is the criteria of SOLO-1 after the end of adjuvant chemotherapy if the patient responding by partial or complete response to chemotherapy. And after that, another indication for olaparib, if the patient receiving bevacizumab in the adjuvant setting based on PAOLA-1 trial, we can add olaparib with bevacizumab in the maintenance setting in the first line treatment. Also, olaparib was approved in recurrent ovarian cancer based on SOLO-2 trial as a maintenance therapy and as a treatment monotherapy in the third line and fourth line in patient with BRCA mutant patient only. Another player of PARP inhibitor is niraparib in ovarian cancer, also the same indication, approved as a maintenance treatment after the adjuvant chemotherapy in first line ovarian cancer, and also in the recurrent ovarian cancer, second line or third line or fourth line as a treatment. The third one is rucaparib in recurrent ovarian cancer, maintenance or treatment after second line of ovarian cancer. So we have three players now in ovarian cancer. How to choose? First point, how to choose in the first line setting to start with PARP inhibitor if indicated, or to delay PARP inhibitor. As we mentioned, it is approved in the second line setting and in the third line setting. This is the first question. Let's see the disease process again of the ovarian cancer. We found that the chance of the patient to be cured and to prolong the first remission is in the first line setting, because if the patient relapsed, the patient is now non-curable. So first line treatment is very important in such a situation. Also, if we look to the SOLO-1 trial, maintenance olaparib versus placebo after chemotherapy in the first line setting. If you look in the first 6 months, we have 20% of patients will progress in the placebo arm without olaparib. So this patient classified as platinum resistant and not eligible for PARP inhibitor. So we can miss this 20% of patients if we don't give PARP inhibitor in the first line. Also, the other patient, 55% of the patient in the SOL-1 trial placebo arm relapsed after the 6 months, and those patients classified as platinum sensitive, and those patients may receive PARP inhibitor in the second line setting if still platinum sensitive. If you delay PARP inhibitor in the second line setting for those population 55%, we have only 40% out of those patients may be platinum sensitive, which is the indication of PARP inhibitor in the second line setting. So we will miss 40% of patients in the second line setting that will not benefit from PARP inhibitor if you didn't give PARP inhibitor in the first line. So PARP inhibitor in the first line is very important. And let us see the clinical benefit of PARP inhibitor in the first line setting and the clinical benefit in the second line setting. This is a SOLO-1, olaparib versus placebo after first line adjuvant treatment in the first line setting. And the SOLO-2, this is a platinum sensitive patient in the recurrent setting. The clinical benefit here in the first line setting, more than 3.5 years, 36 months difference in progression-free survival, but in the same drug, olaparib, in the second line setting in platinum sensitive patient, the clinical benefit only 13.6 months. So the clinical benefit is markedly higher if you use the treatment in the first line setting. So now we will focus on the first line setting indications for the PARP inhibitor. We have 3 drugs now, EMA approved for the first line setting. We will focus on 2 drugs available by 3 protocols. First one, as we mentioned, olaparib or monotherapy, or olaparib plus bevacizumab as a combination therapy after the end of adjuvant chemotherapy. And the third one is niraparib. How to choose? This is depending on multiple factors. The most important factor, what is the PARP indication. Each drug has certain indication inside the pivotal trial used. Also quality of life and toxicity profile of each drug and the availability of each of them in the country. Starting with the indication of olaparib, data for olaparib in the first line setting. This is a very famous trial, as you know, a SOLO-1 trial, phase 3 trial, including high risk ovarian cancer patient after either neoadjuvant or initially debulking surgery, recruiting patient with stage 3, as you see, and 4, endometrioid or high-grade serous, only BRCA mutant patients. So not include all HRD homologous recombination deficient patient, only BRCA mutant patient. And this randomized to olaparib maintenance after the end of chemotherapy in case of partial response or complete response to chemotherapy, not in progressive disease. Randomized for olaparib versus placebo for 2 years. Olaparib treatment in this trial for 2 years. Primary endpoint was progression-free survival. Progression-free survival was significantly longer with olaparib versus placebo. If you look difference in progression-free survival with the addition of olaparib, 42 months with 5-year follow-up, with hazard ratio 0.33. We have risk reduction about 70% from progression and death. Again, there is the long-term relapse-free survival for patient achieving complete response with chemotherapy, significantly longer with olaparib arm, hazard ratio 0.37. And this benefit is maintained for patient with low risk, criteria like stage 3, and higher risk population, the same benefit, hazard ratio for low risk and higher risk patient, 0.35. So this is the conclusion of SOLO-1 that leading to that standard of care now for BRCA mutant patient, for patient receiving only chemotherapy in the adjuvant setting, not bevacizumab. The standard of care is to maintain those patients 2 years on olaparib. The other player is niraparib. Niraparib is tested in this trial, PRIMA study, which is a phase 3 trial, including also high-risk patient. After either neoadjuvant or primary surgery, and the end of chemotherapy, including all comers. Here in this trial, including all patients, either BRCA mutant or BRCA wild, HRD positive and HRD negative. But what's very important in this trial is this trial excluding patient with stage 3 if R0 resection. This is not included in this trial. So if you have patient with a stage 3 R0 resection, it's not included in the primary PRIMA study. After the end of chemotherapy, all comers were randomized in PRIMA study to niraparib and placebo. And the niraparib, as we will mention, we have high incidence of toxicity, hematological toxicity, especially thrombocytopenia. So the protocol was changed regarding the dose of niraparib to be based on weight and the platelet count initially. Primary endpoint was progression-free survival. Hierarchical statistical analysis was done. First, we mentioned that PRIMA including all patients. So we assess the clinical benefit in HRD positive patient first, and if positive, we assess the benefit in the intention to treat population or all comers. And the benefit of addition of niraparib as a monotherapy versus placebo after adjuvant chemotherapy was positive in HRD patient. And as you see, we have absolute difference 11.5 months, hazard ratio 0.43. Because this patient, unlike SOL1, including HRD positive, one of them BRCA mutant patient. And the intention to treat population, overall population, either HRD positive or HRD negative, also the result was positive despite less clinical benefit. If we analyze the progression-free survival based on HRD positivity, we found that the clinical benefit is higher for patient with HRD positive, either BRCA mutant or BRCA wild. As you see, hazard ratio is 0.4, 0.5. And what's interesting is that niraparib is still active in patient with HRD negative. Even the patient has no defects in homologous recombination genes, still niraparib has activity, despite limited activity, but still there is activity, about 2.7 months. This means that PARP inhibitor may act against malignant cells not only by inhibition of single-stranded breaks by PARP enzyme, but maybe other mechanism like PARP-regulated genes transcription inhibition by another mechanism like stimulation of the tumor antigenicity and so enhancing the immune response maybe. This is the conclusion of PRIMA study leading to approval of niraparib in the first line setting after the end of adjuvant chemotherapy as a monotherapy by the dose of 3 or 200 milligram once daily in HRD positive, BRCA mutant, and even HRD negative patient because data was positive for all comers. The other strategy, the rationale for this strategy of BAULA-1 trial is that we have data previously from ICON-7 and the GOG trials that bevacizumab with chemotherapy and the maintenance bevacizumab achieved progression-free survival versus placebo in the maintenance setting, especially in patients with high-risk malignant ascites. So the rationale, why not to combine both bevacizumab and olaparib in the adjuvant setting as a maintenance therapy? And this is the idea of BAULA study, including also patient all comers, either HRD positive, HRD negative, BRCA mutant, BRCA wild, high-risk patient stages 3 and 4, patient after the end of concurrent bevacizumab adjuvant chemotherapy, maintained with bevacizumab and randomized to receive olaparib or not. So we have two arms, olaparib in the maintenance plus bevacizumab for 15 months and olaparib for 2 years, and versus placebo plus bevacizumab. And the primary endpoint for BAULA-1 trial was progression-free survival. As you see, it is positive trial with the hazard ratio 0.63, progression-free survival 260.1 versus 18.3. So in all comers, in HRD positive, also again it was positive trial. Olaparib plus beva is better than beva alone in HRD positive, and in HRD negative there is no benefit. Why in PRIMA studies there was positive for HRD negative, and in BAULA there is no benefit for HRD negative patient? Maybe the effect of bevacizumab in the comparative arm with placebo. What's interesting in this limitation in this study is there is no arm of olaparib as a single agent to identify that the benefit is mediated by olaparib or mediated by the effect of bevacizumab plus olaparib. Again, the benefit was for lower risk and higher risk patient, and the conclusion of PRIMA study as previous studies leading to approval of indication of olaparib plus beva in patient with HRD positive or BRCA mutant if the patient receive bevacizumab in the adjuvant setting to be maintained in the maintenance setting bevacizumab plus olaparib. This is the subgroup of both PAOLA-1 and PRIMA study, and as you see in most of the subgroups, the benefit is the same. PRIMA single agent niraparib versus PAOLA niraparib plus bevacizumab, and we have similar hazard ratio nearly, except in the HRD or homologous recombination proficient patient, which are HRD negative population. The benefit is present for niraparib, not present for bevacizumab plus olaparib. So we need to understand more in depth about the role of bevacizumab. Why single agent give the same benefit of olaparib plus bevacizumab? This is the summary. In subgroups, as we mentioned, both PAOLA and PRIMA near the same benefit, and also, as we mentioned, SOLO-1 have no direct comparison between olaparib alone versus olaparib plus beva. This is again, we can't compare head-to-head trials, as you know, because we have different population in trial, and also we have different treatment schedule in PRIMA 36 months and in PAOLA 2 years of olaparib. But we can proceed for indirect comparison called the population adjusted indirect comparison between SOLO-1, which carry olaparib versus placebo, and the PAOLA-1 trial patient, PAOLA-1 olaparib plus bevacizumab versus olaparib, but we will adjust the patient characteristic in order to proceed for indirect comparison. As you see, for example, in stage 4 disease for PAOLA-1 trial, for example, in stage 4 we have 28 patients in olaparib beva arm and 31 patients in placebo beva arm. We adjust the characteristic of these patients, and so after adjustment we found that the stage 4 disease, for example, is 14 in the olaparib beva arm and 16 patients for placebo beva arm. As you see, after patient characteristic, so we have now, if we back for the arms of this trial, we have now 4 arms, 2 arms from PAOLA and 2 arms from SOLO-1. We combine those patients after adjustment of the patient characteristic. We found that placebo in PAOLA-1, placebo plus beva arm in PAOLA-1 versus placebo in the SOLO-1, we found that there is effect of bevacizumab already. We have significant benefit for progression-free survival and the hazard ratio 0.65. So bevacizumab is better than, looks like to be better than placebo in the maintenance setting. Also, in the SOLO-1 arm olaparib as a single agent versus placebo plus bevacizumab, we found that olaparib single agent is better than bevacizumab in the maintenance setting as a single agent with the hazard ratio 0.48. So it looks like in this adjusted patient characteristic trial, olaparib is better than beva as a single agent. Also, the other arm in the PAOLA, olaparib plus beva versus olaparib, we found that olaparib plus beva is better than olaparib as a single agent. So this population adjusted indirect comparison analysis concludes that olaparib plus beva leads to an improvement in progression-free survival versus olaparib alone. Regarding the toxicity of PARP inhibitor, in order to select your drug according to the toxicity, The most common side effect of PARP inhibitor as a class effect for all players of PARP inhibitor is GIT, fatigue, and hematological toxicity. What's very important is the most common side effect, most in the PARP inhibitor is for niraparib has a highest rate of hematological toxicity, especially for thrombocytopenia as a seed, and this leading to the change of protocols, as we mentioned, to reduce the dose of starting the PRIMA study to reduce the dose based on the weight and baseline platelet count. As you see, if the patient less than 70 or patient more than 77, or platelet less than 150 or more than 150. We should, if you use PARP inhibitor, you should be focus on very important, very rare but very important side effect is MDS and AML, which develop with the time with the PARP inhibitor, median time 17 months, and it is very rare, less than 1% with the use of PARP inhibitor, but you should be cautious and you should counsel your patient for frequent CBC in order to detect pancytopenia, which may be early a sign of MDS or ML. Also, we have elevated serum creatinine, especially with olaparib and rucaparib, maybe interference with the excretion, not direct effect on the kidney. Also, you should be cautious about hepatotoxicity, especially in rucaparib, and toxicity management usually with experience about your dose reduction, cessation, or even treatment discontinuation. Regarding the quality of life, all drugs didn't affect the quality of life in the maintenance setting, as you see. So in conclusion, this is the faculty experience getting the right medicine to the right patient in frontline setting. If the patient is HRD positive, and if you use BEVA concurrent with chemotherapy, your option now is to add olaparib with BEVA in the maintenance. And if you didn't give bevacizumab, so your option in HRD positive is niraparib. But if the frontline setting, the patient is BRCA mutant, olaparib is the best drug can be considered. And if the patient starting again with bevacizumab, no any data about any PARP inhibitor in the maintenance setting with bevacizumab except olaparib. This is the guidelines, and you should focus on 3 decision points. First decision point is to start with chemo or start with primary debulking surgery. This is the first you think about with your patient. Decision point 2, when you start the chemotherapy, to give BEVA or not to give BEVA. This is the decision point 2. Decision point 3, after the end of chemotherapy, what's the type of PARP inhibitor indicated? If patient was HRD positive, you have niraparib. If the patient receiving BEVA, you have olaparib. If the patient BRCA mutant, you have olaparib, either with BEVA or without BEVA. Thank you.
Thank you, Professor Ahmed.
صدعتك صح؟
Dr. Najah will have a question.
هتقول لك 2 question مش كل واحد.
I have 2 questions. The definition or the cutoff for definition of HRD positivity used in PRIMA study and Paula, was it the same in both trials?
Yes, Nira and Paula using my choice test, the same test for genomic instability. And if the patient is less than 42, it's not benefit from PARP inhibitor. 42 or more will benefit from PARP inhibitor, either BRCA mutant or BRCA wild.
The same for both
The
trials.
same.
Okay. The second question: what if a patient with HRD positive, BRCA wild, and having any medical condition that she cannot receive anti-VEGF, for example, thromboembolic diseases or what? For what PARP inhibitor will you go?
We have data from
She's HRD positive but BRCA
BRCA wild,
wild.
niraparib.
Okay, thank
niraparib.
you.
Okay, thank you, Professor Ahmed. And I think by this we can end the session. Thank you all for listening.